Okay, so I guess we should get started. It's just after 1 o'clock. So it is my pleasure to be introducing Professor Catherine Maitland today. I know it is unusual for a person, so I'm Victoria Austin, hi. I know it's unusual for a PhD student to be introducing, so I really hope I do it justice, although she's been very clear I'm not to put any praise in this, so we're going to keep it just to basics. So Catherine is actually from Liverpool originally, although she studied medicine at St Bart's in London, before moving to South India, working there, and later in the lab of Professor Sir David Weatherall in the South Pacific. Her work there on the protective role of thalassemia in malaria infection helped shape her career of asking the difficult questions, and I think we'll hear more about that today. Catherine has been based in East Africa for almost 20 years, where she leads a group that has highlighted the importance of acute emergency care in managing childhood mortality. Her work encompasses severe malaria, bacterial sepsis, and severe malnutrition, alongside clinical trials in paediatric emergency care. Since 2018, she has led the Severe Malaria Africa, a consortium for research and trials, which is a multidisciplinary team, including world leaders in both severe malaria and clinical trials. So I'm going to hand over to Catherine now for her talk on the largest trial in critically ill children in Africa, examining fluid resuscitation strategies in children with severe febrile illness. So thank you, Catherine.
Thank you for a lovely introduction.
You're welcome.
So I often get asked the question, how did you get to do what you're doing? And so I'm going to be quite sort of selfish and indulge myself and talk about my favourite topic to start with, me. So you might be surprised to know that I've not always been a professor of fluids. I started off, obviously with the introduction said I was trained at St Bartholomew's, but I was doing my paediatric training, and I went, and I don't know whether the course still runs, but the WIPS cross course for MRCP, it still runs, and that was in 1990, and this is the first lesson, follow your heart. I met this gentleman on the course, and I think half the audience knows him, but probably, yes, this is the young Tom Williams. By the end of the week, I'd announced to my boyfriend that I've already met the man I'm going to marry. And 3 months later, we were engaged, and we'd both resigned from our posts, and we were off to do, well, it used to be called tropical medicine, global health. So we thought, well, where are we going to do this? Obviously, this is something our common aim. So we thought, well, we've heard of the Gambia. Let's write to the Gambia. And this is what we did, and this is the response that I got back from the then director. So you can work out who that is for people who know. Everybody needs a lucky break, and my lucky break came with this gentleman. We saw a job advert for the New Hebrides. They were looking for a paediatrician, an epidemiologist, or a haematologist. And we actually had our bags packed. We were about to go travelling. And Tom picked up the phone and was put through to Professor Sir David Weatherall. I couldn't believe that he had the nerve to do that. We went straight up to Oxford. I was bricking myself because there was two things I didn't know anything about. A, alpha thalassemia. And this was the time when there was no internet. You couldn't quickly Google it. And B, I had absolutely no idea where the New Hebrides were. And I realised they weren't just above Scotland. They were and this is Vanuatu. Steve, this is probably part of Steve's story as well, because you were also involved in a similar project up in Papua New Guinea. And so that was in 1991. These are the people that we had to work with. And we were obviously, as I said before, that we were looking to see whether alpha thalassemia protected you against malaria. Just before we left in September, John Clegg said to me, "You're not going to go to Vanuatu to have babies." And I was absolutely shocked. This is my first research project. Of course I'm not going to do that. Well, 3 months later, I was pregnant, and this is our first research output. And then that was our second one. So we had a bit of a crisis because we'd just come back to see the family just before Christmas. And I thought, what's this? I was 18 weeks pregnant, and yeah, it's going to ruin Christmas was one comment. So we had a rapid marriage. It's the worst wedding I've ever been to. But it's lasted, and that's us 25 years on. This is just before Christmas. So still with the man. And it was perfect. John Clegg and David Weatherall were very happy. We were on a community-based project, and we just took our kids along. So 3 years back and time to find some funding. There was one post that was going to be funded and Tom took that, so I had to go in to the Wellcome Trust and try and get a fellowship around epidemiology. So I wasn't always a professor of fluids. I was put in a fellowship, and you don't receive the reviewer's comments until after you've been interviewed. And I just couldn't understand why my entire interview was about Anopheles frauti sensu stricta, because I was asking questions around human health, not around mosquitoes. Then I realised when I got the actual comments back that this was one of the comments, and this was another of the comments. That actually, at the time, wives went out to help their husbands. They didn't go out to do their own pieces of research. And so the reason why I was being asked about something that they thought I couldn't simply know anything about was that, yes, and so I got the fellowship. I knew plenty about that little mosquito. So we had a good, successful output. And, you know, we obviously had more outputs as well. But it was time to move on, because whilst we had no conflict between ourselves, I was still recognised as Mrs. Williams, effectively. And so I needed to put a bit of clear water to it. So now to the actual main topic of the actual, so the origin of the FEAST trial. So why was the FEAST trial necessary? And I'll explain a little bit about the actual, what we were investigating. At the time, people were investing in community-based work and other, you know, studying things, but actually intervention at the point when a child comes into hospital as a health priority, as a way of saving lives, had never been seen as an important priority. So it was actually pretty hard to actually get funding for this. These are areas where there is no access to intensive care, so you've got good clinical acumen, you can do clinical trials, but other than that, there's no backup at all. So this is the hospital that I was at the time. This was St Mary's Hospital, and they started, by the time I'd come back into the research after my break in Vanuatu, everybody was doing ETAC courses, they were doing APLS, and I thought, well, if we could apply some of these sort of principles to the sick conditions in Africa, particularly malaria, this actually might be a very good, cost-effective way of saving lives. At the time, all of these therapies that you would probably reach for in the emergency room, this fairly standard therapies, none of them had been tested in clinical trials. So they're all being recommended without any trials. 19 years on, I'm pleased to say that actually that position has completely changed. There's obviously ongoing research in oxygen. Transfusion trial has just been finished and the results are under review. So we have been able to transform that. And I'm going to talk specifically about fluid resuscitation and the FEAST trial. These are the type of hospitals that we see, that we have absolutely stuffed full of children, and the emergency room is, you know, has very, very limited facilities. And just so you can get a flavour, I'm going to take you to the bedside of really this is my
5-year-old Achien Loi has just arrived in hospital with suspected malaria or sepsis, a bacterial blood infection. Every year, these illnesses kill more than 2 million children worldwide. There are effective medicines, which Achien is being given, but she's already in shock. She has a weak, rapid pulse with cold legs and arms. Her body is concentrated.
So she is very sick. She's in coma. She, as Dr. Ngoro was telling you, she's in profound shock, and you see her saturations, and her base excess was -28. So this is the type of child that we try and manage and try to keep alive. Yes. So before we did the FEAST trial, we invested a lot of time actually seeing whether fluid resuscitation, this particularly in malaria, was safe. And, you know, and these were dose-finding studies which we did it against a CVP line, which it measures the actual column of blood, the pressure of the column of blood coming back to the heart. So we were able, that was very low, it was below normal physiological levels when we were actually, the children being admitted. And we were able to show doses of between 20 and 40 mils per kilo of saline or albumin, put it back into the normal range, but we also were able to observe that they actually didn't cause fluid overload, which was obviously one of the big concerns. So while we built up the sort of information behind the FEAST trial, looking at all different types of fluids, and actually finding that, this is particularly for malaria, we selected albumin to be in the trial rather than just doing a trial of saline alone, because in malaria this was something that had a very strong signal for a much better outcome. And so we felt that this should be in the trial. We submitted the grant, or I submitted the grant again and again and again, and everybody had a strong opinion. And so when people have a strong opinion on both sides, that's a good grounds, that's what's called equipoise. But the strong opinions won. And this is what Tim Peto says, that clinicians have fixed but unstable certainty. One day everything's absolutely brilliant, and the next day. And so that's what you have to deal with in a... sorry about this. Sorry, Mum. But you have to keep going. And as one of the photographs that I've got, that you never give up. Because if you believe this is a really important question, and it took us quite a number of years, but finally the FEAST trial was funded, and then I thought, crikey, I've got to set it up now. So there was no off-the-shelf package to say, this is how you run this trial in these type of hospitals. So there's an enormous number of people involved with any big clinical trial, and we realised that actually if we were just going to do a malaria trial, a child doesn't come in with malaria tattooed on the forehead. We wanted to make it a pragmatic trial, that actually the questions that we were asking were important not just for malaria, but they were also important for sepsis and all these whole range of possible conditions that can present in the critically sick child. So we wanted, that's what I mean by a pragmatic trial. You don't have to go off to the lab to find out whether you can enroll a child. You can enroll a child as they come through the door, based on clinical signs. I don't know why I've added this, but you realise that, we had this is where most of the, we did the studies, and we did it to a very high standard, but we had to put lots and lots of things in place. The design of FEAST was a fairly simple design. The large part of the trial was a controlled trial where children received either a bolus of albumin or a bolus of saline, or control, no immediate bolus. They would only receive a bolus if they dropped their blood pressure. And we were only allowed 2 boluses because we were concerned that if you keep on bolusing child, then there's no backup, there's no ICU to go to. So that was essentially the design. We have simple outcomes, mortality to 48 hours. You can't really argue with if somebody's dead or alive. That's a fairly sort of hard endpoint, and mortality to 4 weeks. And also, we were at every time that a doctor went to see the child, at 1 hour, at 2 hours, at 4 hours, at 8 hours, they all had to look for signs of whether the children had developed any of the complications that we were concerned about. Certainly hypertension is what we were concerned about for the no bolus arms, and then fluid overload outcomes. And so they were specifically looking for those to see whether there was any concern. This is before, and we didn't just do a fluid resuscitation trial, we did better treatment plus fluid resuscitation or not. So we felt it was totally unfair not to actually provide some basic standard of care, and that included giving oxygen for those children who needed it, giving antibiotics. Quite often these hospitals run out of antibiotics and parents have to go, so there was a standard pack. So everybody got the same standard of treatment and supportive care, and the only thing that differed between the arms was what the fluid boluses they were getting, or what type of fluid. We did training, not just before the trial, but throughout the trial. But this was absolutely essential to ensure that the sickest children were picked up, they were looked after properly, and also people followed the trial protocol. So we had to operate within GCP guidelines, and so this is really, we also wanted to get the sickest patients into the trial, and we didn't want it to be detrimental to parents. In other words, all they're concerned about is their sick child. sitting down and saying, we've got this clinical trial, they will say yes to anything in this, they're desperate. So we actually developed an emergency consent or assent process, which all of the ethics committees approved, and so that meant that we didn't adversely affect the parents in the trial. These two boys monitored absolutely everything, 100% source document verification, and that's what we called them, the friendly policemen. They trained people to start with, but then they stood back and they were independent. And people were upset to begin with that thought that they were going to, they were not there for the right purpose. Once they understood that this was just, we're making sure that we're doing a good trial, they understood our friendly policemen. So this is what London was seeing. This is the trial recruitment by arm. So there's actually 3 graphs in one, so they can see that there's no wiggle, that people are actually following what they're meant to be doing. There was no wiggle. And it started in January 2009, and 2 years later, I got a phone call. So this was the 5th interim analysis, Tim Peto and the chair of the DMC said fluid resuscitation can be of no benefit to children in Africa. And I couldn't understand what he was saying. And I said, well, what do you mean? Do you mean that we've done a bad trial? No, he said, no, have you understood that? He said, right, the second thing I'm going to tell you is that they're going to recommend the trial to stop because fluids were harmful. But I don't want to tell you that until I want you to see what the doctors thought. Because
then surrendered to Uganda to be told the result. Until then, only a few of us knew, and we were sworn to secrecy. The scientific paper was now ready for publication. Before the presentation, I asked nurses and doctors to try to predict what the result would be. Which treatment was better?
So do you think the bolus worked or did it work?
We believe it worked so much. Because they were dying patients and they were sick.
We had our first patient who was brought in a moribund state, and after the initial bolus, the girl got up and asked for a drink. So by that, it made us feel that fluids are actually very important, and it's good that we administer them rapidly.
Yeah, going by what I've read and what I've experienced in treating some of the children that have boluses, I think some of them benefited.
Yeah, according to how I've been observing the children who have been treated, they've actually been coming up after giving the boluses.
Based on observations, kids who received boluses actually improved quickly. So I think boluses really help in the immediate outcome.
So this wasn't a selected number of people, just because they were just saying what I wanted them to say. Everybody said the same thing. They were all absolutely sure that that's the result that I was about to present to them.
Then surrendered to Uganda to be told the result.
There we are. So this is why the DMC asked us to stop the trial. This is the interim analysis. As you start, you see to start with, it looked like fluid boluses. If the sort of diamonds towards me, it means fluid bolus is a benefit. If it's away on the other side of that central line, it means fluid boluses are harmful. So you can see that if you do tiny little small trials, so you have to do large trials, and large trials tell you what the truth is, and that's why they couldn't stop it before then. You see that only the result, and there's some people viewed that the trial was stopped too soon, or it didn't statistically follow the Hale-Brittle-Peto rule, which is 3.01 for a p-value. It was stopped because it was harmful. We could not carry on to chase a p-value. That was the DMC and the statistician made that very clear. So the actual result was a 3% difference in the boluses in the first 48 hours compared to the controls. Interesting, although albumin and saline have different physiological properties, you couldn't really put a cigarette paper between those two lines. Actually, their mortality was identical to M10.5%. But you see, obviously, what makes a very, very clear gap is the no bolus arm. Children didn't hang on in the bolus arms and then suddenly die later. The actual gap between the bolus and no bolus arms got wider over the first 28 days. So once again confirming that the secondary endpoint, mortality. This was a paper that's just been submitted by Lizzie George, and she's been looking at risk over time. So most children in the FEAST trial only received a bolus of 20 mils per kilo, which some members of the team suggested was homeopathic. We should be giving more, and this is why the trial hasn't been stopped. If we were giving more, then we would show that fluid boluses are good for things. But actually, knowing that most only had 20 mils per kilo, actually the risk goes out to 4 days. So children keep on dying just from what some people, and a much, much lower dose than is currently recommended by the WHO and certainly in international guidelines. So I think this is what the doctors were responding to. So we were asking them to report anything, because we didn't want underreporting. And so these were what were reported, and we had an endpoint review committee that reviewed all of the endpoints, and they had access to all of the clinical narratives and blood tests and their sort of hemodynamics, and were able to. But they didn't know what the arm they were in, so they had to judge these based on, they were, as I say, blinded SAEs, and there were relatively few overall, because remember this is 3,200 children, and most were judged as unlikely to be associated with the intervention strategy. So we got a fast track into the New England after a presentation that I did in Australia. We were very pleased to know that the FEAST topped the awards the following year. But there was a lot of controversy around the trial, and lots of questions around why was it necessary to do this trial, with people stating ethics on both sides. Well, certainly people could have a go at us about that, but they couldn't actually undermine the methodology and also the excellent conduct of the trial, and I obviously have to go back and thank all of the nurses and doctors for the way that they followed this. You don't normally see this in a clinical trial, that you've got, everybody sticks to what they're meant to be doing, and for the primary endpoint, often you have a few patients that you don't know what happened, but we had almost 100% retention, so it means that actually the result is robust. Lots of people saying, well, they're obviously not very sick, who was enrolled in the trial, and everybody's focused on the fact that these kids, the only kids that died were the kids who had malaria and sepsis, even although it was malaria and anemia, even although it was quite clear from the primary publication that this was not the case. People were asking if you already knew it was harmful. Well, no, we don't. We didn't see any data. That's the absolute importance of this. It's an open randomization, that we don't see the accumulating data. And why did they increase the fluid boluses? I mean, this was around a particular person wanting the high boluses. And obviously there's a lot of discussion around the definition of shock. Well, let's take you back to that first comment that, it was, well, first of all, people said they were all got malaria. Well, no, they didn't all have malaria. 40% didn't have malaria, and from what we know, that many children will be carrying parasites, but their current illness is not necessarily malaria. We had quite a large subgroup of children who didn't have anemia, and when you say they weren't pretty sick, well, lactate over 5 in 30% of kids, 35% of kids, they're pretty sick, and many more being acidotic. 12% had a bacteremia. So the idea that who we enrolled in the FEAST trial were not very sick was ludicrous. We were able to, because we obsessively recorded things, showed that actually we did have separation between the two arms, that actually the no bolus arm did not receive boluses. They weren't receiving rapid maintenance either. So we had looked for every subgroup. We've done loads of analysis, and the statistician said in his 30 years of doing clinical trials, he's never seen such a consistent result. There is no single subgroup that we can find any benefit in, and he said that means it's a real result. Whichever shock definition, and most of these shock definitions have never been evaluated against physiological markers at all, that people have just created them. So FEAST we really thought very hard about our definition, and it actually was somewhere between ACM and PALS, but actually WHO shock, if you had that, then you had a much, much worse outcome. We're just going to come back to that important. then it's the, oh, well, what about the subgroup with culture, the sepsis and this? You know, actually, no, we've looked at all of this. There is no subgroup that is of any benefit. And so we actually published, because people keep on saying it was anemia that was driving this, but this is once again a forest plot of, it starts off at a hemoglobin of 3, and 4, 5, 6, all the way through to 11. And if you can see, all the diamonds are on the other side. So that means fluid bolus is harm, and it's almost identical. There's no heterogeneity in that result. So it wasn't the hemoglobin that was driving that. So what was causing the excess mortality? Well, we saw fantastic response to fluids. Shock reversal at 1 hour. Yes, exactly. That's what the nurses and doctors were seeing. But it actually, shock reversal at 1 hour, which is one of the standard things that we try to aim for in the as recommended in the guidelines, that didn't protect you from dying. As I say, they seem to have almost a worse risk of poor outcome. Shock signs, well, we just just look at the diamonds. So as I said, there's no single sign or subgroup that we could find. So what actually happened? So because we had an endpoint review committee, not only did they review the SAEs, but they also said what the mode of death was. Was this mainly a respiratory mode of death, or mainly a neurological mode of death, i.e. we think that we're causing raised intracranial pressure, or was it basically cardiovascular collapse? And so this is exactly what we saw. We saw children who basically reversed shock, and then they went very, very rapidly into lethal shock. Unresuscitatable lethal shock. The reports were just, almost. So that really was the main explanation for the excess mortality. I think so I'm just going to flick on, because I know I've covered far too much already. And I think we just have to reflect what the actual guidelines are for the rest of the world, because everybody said, well, we will still follow our guidelines because it's based on trials, but this is the pediatric guideline, and you know this very well, Paul, that it's not based on trials, and it's patients, survivors to ICU. So already there's a bias there, and they basically looked back at basically 7 children a year, and I don't tell you that many more children in this tertiary referral centre come in with shock. And they basically said if you receive 40 mils per kilo, your downstream outcomes are much better. So that set the guideline to 40 mils per kilo. The second study, exactly the same design, said, well, actually, if you give 60 mils per kilo over 15 minutes, community physicians, most specialists in emergency care can't give these rates of fluid. They actually have to have special perfusers. So you can see that this informed the paediatric guidelines worldwide before the FEAST trial. It's still there. Yes, if anybody is interested in this area, there's an absolutely excellent sort of review of what, even when people say, well, all the mouse models are being done. No, it hasn't. And so it's a very good critique of fluid resuscitation. And it reminds us all, like anything that we give, it's a drug. So it might have beneficial sides, but it also can have harmful effects. We sent WHO a policy brief that actually ran to about 300 pages with all our sub-analyses, absolutely everything. And they sat on their hands because we felt that this was, I was being told that I had a conflict of interest because I was promoting my work. And I said, no, children are dying. But they ignored it, and 2 years after the trial, they published this, and fluid boluses continued to be recommended, and in higher doses, and repeated 3 times. And this is the current recommendations. So that sort of, we were rather upset. So we actually wrote this in and calculated, as a result of these recommendations, how many children, and according to the definitions of shock that you would use, how many excess deaths would actually occur each year for fluid boluses, and it runs into the thousands. First, do no harm. That was the title, and I don't know why I've put it here, but it's certainly the meta-analysis that was commissioned actually by MSF. They changed their guidelines, as have other agencies. They based it on this meta-analysis, but basically just said, which was largely informed by the FEAST trial, that actually fluid boluses are harmful and that they should not be given in the conditions that we were treating in FEAST. I think this came out later. They focused almost entirely on the WHO group, a subgroup, a very small subgroup, who had proper WHO shock, ignoring the rest, saying that actually this group was relatively small. They downgraded it. They said the size of the trial, and they called it a trial, and it wasn't. They're part of the big one, the overall trial, and indirectness. So as a result, they supported the WHO for this particular subgroup. This is once again reiterated in a recent update. This is 2016 of the guidelines. Now, if you actually read this, they have got the FEAST trial results, but they're enumerate. They can't actually report proper numbers. The numbers are wrong, but they still say that they recognise the impaired perfusion, i.e. with who we included, but they said for WHO shock that they must keep on receiving doses of fluid, which is a tragedy. So we decided to say, well, actually, and they were sort of saying, well, if you have hypertension, then you should also, but hypertension is quite a late sign, and a late and fairly almost lethal sign in paediatric shock. We had, as I said before, we had an ASCENT process, and we could get the sickest of children into the trial, and we screened thousands of children, and we actually only found hypertension or severe hypertension in 29 children. So it is a rare late feature. So we have to rely on other signs if we're going to treat the shock. So we assembled data from hospitals in Kenya. Some are published, some were unpublished. As you see, it's nearly 100,000. And we found WHO shock in about 170. So it's a population that doesn't exist in practice. And outside of the FEAST trial, it has almost a unifold sort of mortality, a massive mortality. So it's a group that have a high mortality that hardly exists, but justify the WHO from continuing to recommend fluid boluses. Our real huge concern is slippage. The difference between a capillary refill, I think, Chevron, were you at the meeting in Mombasa recently? And I asked doctors or paediatricians to put their hands up if they were giving fluid resuscitation, and loads of hands went up. It was so depressing. It was the first sepsis meeting in Africa, and I said, well, who are you giving fluid boluses to? And I heard people saying, well, if their conscious level's down a little bit, if they're not been drinking. I mean, all of this rubbish about sort of WHO shock, you've got to have 4 signs. Nobody knew that. Nobody could actually quote that, even although they'd all done ETAT courses. So but the thing is that even although you could say, well, that's a small group, that subgroup would still have the 3% harm of the fluid boluses, because they still also had, so that indirectness is not relevant. It's the actual importance of the actual effect rather than the size of the group. So, evidence-based medicine. Do you remember a little Latchin Loy? Well, she was a recipient of evidence.
She fought for life in the emergency room, unable to drink until the following day. During that time, 2 other children died on the table next to her.
Disability-free survival, and nobody would have predicted that. And I think that's important that we do these trials and we keep on hammering the drum and saying,
She fought for life.
Oh, this is a disaster of a start. Well, so what are the unresolved questions after that? So there was large groups that we didn't include: severe malnutrition, gastroenteritis, and febrile illness. So we have been involved in doing further work, and I'm only going to briefly touch on this. We did Feast in Sheep in Brisbane. This is Bunya, Chifatso and Bunya. He was out there looking at myocardial function in this, and this was published last year, effectively showing that if you induce, this is an ovine model of sepsis, which they induce it with endotoxin, and then they were trying to keep up the blood pressure. And so those who had a bolus actually had a much, much higher vasopressor and noradrenaline requirement, and also I've not put my glasses on, that they also, the markers of myocardial damage, myocyte death, and also the AMP were significantly higher, suggesting that this is having an adverse effect on myocardial function, which is consistent with what the FEAST trial showed, that it was cardiovascular rather than fluid overload. We've just completed a phase 2 trial looking at slower fluid replacement in gastroenteritis. At the moment, these children, Plan C gives them 100 mils per kilo over 3 to 5 hours. That's well, almost twice your circulating volume, and bolus is on top if you've got shock. And so we were concerned about the fact that giving rapid fluid resuscitation was harmful. So we were doing slow rehydration over 8 hours rather than the Plan C. This is what it says, and effectively all our primary endpoint was adverse events, so there was no difference in adverse events, but every other parameter that you are meant to look for in terms of correction of dehydration were fine. But this is interesting. This is atrial natriuretic peptide. This is a marker of atrial stretch, and it could be a marker of damage. This is unpublished. We've submitted it, but you can see that it's almost within the normal range when children come in. These are very, very dehydrated children. By 8 hours, it's off the scale, and it stays off the scale till day 7. So there is something happening. We can't explain that. It hopefully will be in the public domain, but there's almost a consistent story there, and that's the end. Thank you.
Right, so I guess we've got time for some questions. Does anybody want to start?
Hi there. My name's Ben Morton. I'm currently based here, but will soon be in Malawi. And I'm actually fielding questions from people who are watching you live stream from Malawi. So I've got a question here from Jamie Rylance. Given suggestion of Andromeda in adults this year, that titration to cap refill might be more beneficial than titration to lactate, do you think chasing titration techniques is important, or across-the-board reduction is likely to be the best option to reduce harm? Caveat about adults versus children, exclamation mark.
That's quite a technical question. I mean, when I'm frequently asked, so who would you give fluid boluses to? And I said, well, I don't. And they said, well, if you're going to target something, sometimes targeting surrogate markers don't, as you saw, shock reversal did not. In fact, it was worse. So they're quite difficult questions unless you actually are able to embed them within a trial and then go back and look at them. And that's what we try to do in the FEAST, that you collect all of that information, and that if you have a signal from a trial, and I believe that that's what Jamie's doing. I reviewed him, and I think he would be wise to make sure that information is gathered, and that will allow him to actually look back retrospectively.
Wonderful.
Because by doing it just as a single observation, it's quite...
Okay.
Hello. As I was saying to you, Kath, my ears aren't working at the moment, so I might have got quite the wrong end of the stick. But I was interested in the cardiogenic shock aspect of the study. And I was just casting my mind back to the Frank Starling law of increasing end diastolic volume, finally producing a reduction in cardiac output in a failing heart. And so I can sort of understand that, but I don't quite understand how a previously healthy, normal myocardium would be failing under these circumstances. Is it things like acidosis that particularly produced that?
I think, so the children didn't go into biventricular failure. So they basically, you reversed their shock, as you heard from the doctors and nurses. Can you, oh, it's meant to be here that I'm speaking, sorry. In there. So it wasn't biventricular failure that they were dying of. They were actually reversing their shock and then going back into lethal shock. Their blood pressure fell and it was catastrophic. And you couldn't resuscitate them back. So we had suggested when we published that actually this mechanism is probably protective. So you're actually removing the mechanism that's preserving your circulation to your vital organs.
Yes.
And yes, they're still sick, and they've still got, too early on, while you're still treating the conditions that have brought them in, if you rapidly reverse something that was probably protective, then that's bad for you. I think the lessons is do things slowly. I know people in the emergency room don't like doing that. They like to sort of jump in under they just do things slowly. And the nurses and doctors said the control kids, as you saw Action, she took ages to come up. It was almost 24 hours, but you could see she could hardly sit. She was being helped up and drinking, but it took a long time for her to come up, but you saw her 3 months later. So, and it's counterintuitive, but we think that might be the mechanism, but we don't have proof. There's one person that's been putting their hand up for a long
I'll have a quick question then. Obviously, you've done these very ambitious trials, and coming up with results that were counterintuitive then creates problems, especially persuading the community who think otherwise that they need to change practice. Are there any general lessons to learn from that? Should we be better at engaging people before we even start, so that they're pre-warned and will accept the evidence, blah, blah, blah?
So I did engage with the WHO. I went to Geneva and I was meant to be giving a seminar so I could talk about the trial and why we were doing this, and it had never been publicised. So when I got there, there was no lecture, there was no seminar, there was nothing, and they quickly assembled a few people around the table who were all looking at their watches, and they said it's really, really good that people come and tell us about these so we can be prepared. And I said, well, I'll let you know the results. So we phoned them up and they just refused to talk to us. So we had tried to do that. We had a pre-planned dissemination plan, which we thought was going to go the opposite way, but there we are. You've got to just let the data tell you what the results are.
Hi, Kevin Mortimer. Thank you so much. It's wonderful to hear this challenging of the conventional wisdoms and providing answers to questions so clearly. I had two questions. Steve asked my first. So the other was, if you were starting again, what kind of things might you do differently, if anything?
Well, I think it was successful, so I think I can't. Would I have done? I would have liked it to be multi-continent, because everybody said it's just one trial, but actually it was 6 centres. It would be very nice if another trial would happen in a different part of the world, but I think the energy that you've got to have to actually do these trials. My kids used to call it the effing feast trial. Mum's always talking about the feast, but you have to live the journey as you're doing, because there's always a crisis. You're always having to spin plates. But I had a wonderful team, and I think it would have been nice. But I mean, focusing on just getting those 6 centres going, and the PIs led the research in their centres. I wouldn't go to a hospital and have a PI that I couldn't trust. I couldn't trust that they would lead it. So I think that it was also very much I was very lucky.
Kat, that was a really excellent, thank you. And I just want to go back to this belief disconfirmation bias. Here you've got a brilliant question, fantastic trial, really important results that have huge impact, and yet you get treated in this kind of way, as though you've not done the trial properly, or that it must be a subgroup, or all this doubt is being thrown at you, and then you are constantly justifying what is an excellent piece of science, which seems somehow wrong.
The thing is, I think for people to, the trials are being done now as a result of, the adult sort of certainly the ANZICS groups, the Australian New Zealand critical care groups, they're all beginning to do conservative fluids. I mean, they moved with this idea very, very rapidly. I think it's taken paediatricians who are, you know, said that, you know, we're sticking with our guidelines. A small trial was done to see whether it was feasible to give a lower volume, and they had to stop the trial because the people weren't in the standard of care arm. They weren't following the protocol. They were preferring the conservative arm. They were happy to do that, and I think people have become more conservative. So I think it's nudging there. I mean, how long did it take for smoking and for people to change? Yeah, I know that there's a finance involved in that, but it does take a long time, and you just have to be patient, but just keep on.
Hi, 2 questions. One from, an excuse for pronunciation, Pui Ying Iro Tam, I might have said that wrong. So she asks from Malawi, how do you treat shock now in Kilifi?
We don't give fluid boluses.
Okay. And then a question from me.
Else you have Cass Maitland to answer to. No, I don't really know. I get.
Question from me. So I'm an adult intensive care doctor, and in the adult world, we're now finding that giving fluids isn't necessarily of benefit either in both lower middle income countries with the work in Zambia, I think it is, and also with even work in estates where giving fluid boluses doesn't infer mortality benefits. It didn't seem to do harm necessarily, but it didn't do benefit as part of a bundle in a recent prospective cohort study. I wonder if part of the reason why harm's being found in lower middle income countries might be because of a delayed presentation, and I wondered if you had any comments about that the patients are coming in much later and much sicker, and that the kind of, as you said, treating them quickly at that stage might be harmful then.
I mean, it's very difficult to say. That has been suggested that actually, you know, we get in earlier, but you can't change that reality in Africa, and that's what the result is. I certainly wouldn't want to do another trial in less sick children who had only been unwell for a day. I mean, it doesn't make sense. So, I mean, there will be a spectrum across there. So if we did find a subgroup that had said that they'd only had a fever for a day or so, then, you know, but we can use markers that you can look at your sort of cytokine profiles. We might be able to do that, but we do have a biobank, but you need money for that. So, but it is, yes, it's an interesting hypothesis.
I think we've got one more in the middle.
Hey, I was just wondering, you said you didn't include children that were malnourished, and I was just wondering how you determined that status to include those children into the trial and why you didn't include them.
That's a very good point. We didn't think we'd get it through ethics if we included children with severe malnutrition. I mean, effectively, it was, you know, they should have been included, but the thought was that these children, the malnourished heart, is at high risk of fluid overload, and they can't tolerate a sodium. And if actually go back and look for the evidence on that, it's very, very weak, it's very poor. You know, everybody, you know, wouldn't dare give a malnourished child a fluid bolus. We identified the children basically with signs of severe wasting, a MUAC because they all had a mid-upper arm circumference, or evidence of kwashiorkor. So it was a clinical. We weren't going heightened, you know, that was just too complicated at admission. So those are the 3 signs that we used. So we do have a spectrum of children, of their weights and their nutrition. We should publish that. Again, we're not going to say anything. I'd be quite confident. But I just want to promote a paper that we've just published in JAMA Open that actually looks at the myocardial function of children with malnutrition in cases, and also severity matched controls, which effectively concludes that yes, that the malnourished heart is shrunken, but this is in proportion to the muscle mass. So it's overall, and it actually normalizes over 28 days as the child gets better. The heart functions in exactly the same way as severity matched controls. We see arrhythmias, but they weren't associated with any clinical events. So it's quite a comprehensive study, and we hopefully might go back to WHO and say, do you think you might reconsider. Because children with malnutrition often have diarrhea. They are being denied intravenous fluids. And we're doing a small phase 2 trial, about to start that, to see whether we can liberalise that. So that's going against what I've just shown you, but we think there's a group that's not receiving intravenous rehydration, and we think for the wrong reasons, because they have a very high mortality.
Fantastic. I think that's all that. Oh, we've got one more.
Thanks, Kath, for a great talk. So this question kind of comes with two qualifying statements. One, that I'm probably remembering this incorrectly, and two, that I'm asking you to answer a question that's not within the clinical trial, but sort of using comparing data. But so if I recall, you've had a number of other studies with severely ill patients with malaria in similar settings that have shown mortalities that are quite a bit higher, in the 20s and 30%. And if that is the case, the mortality in FEAST,
yes,
is quite low, and obviously the questions that were asked in FEAST didn't really look at that drop from down to 20+% to down to 11%. Have you thought about sort of a clinical trial that might be able to sort of tease out what really dropped that mortality so that's reproducible for future care?
Well, I think on the basis of us doing the trial, at the start of the trial it was 20% mortality, and we basically halved it by doing the trial, by identifying sick children, giving them a standard package of care and monitoring them. And so the Royal College of Paediatricians liked that message and tried to push out ETAT and got funding for that, to teach doctors to do this, which I think is very, I mean, that allowed me to sleep at night. I mean, I'd gone to hospitals, they weren't giving fluid boluses, and I asked the doctors to be involved in this trial, and I just thought, crikey, I'll never be welcome there again. But it was the chair of the DMC said, no, at the start of the trial, this is what the mortality was. So the intervention is obviously being able to identify a sick child and monitoring them. That needs pairs of hands, and that's but if you could say that to governments, that actually, or policymakers, that is important. To actually demonstrate it, you'd have to do I don't know, you can't randomise children in a single setting. You'd have to do a cluster randomised trial, and with generally, and it would have to be quite large. But it's an important, I think first of all you've got to work out what other things are you doing, and so we're trying to sort of see, do you need a transfusion? Do you need oxygen? And perhaps when we've worked out that bundle, maybe we can go back and say, this is what you should be doing.
Great,
did I answer all your questions? Yeah.
Great. So I think we've run out of time, so thank you again.
Thank you.
Thank you.